Typically, colon cancer is diagnosed via colonoscopy, and that could be either during screening or for diagnosis if somebody's having symptoms or some sort of GI complaint. General surgeons perform colonoscopies. They can also be done by gastroenterologists or some primary care or internal medicine physicians. Usually what will happen is if a lesion's identified, a biopsy will be taken. Once final pathology comes back that may show colon cancer, they are typically referred to me. The surgeon typically participates in staging workups for colon cancer, and that just includes CT scans, typically of the chest, the abdomen, the pelvis, and then some basic labs. And as far as treatment, it depends on a patient-by-patient scenario. Typically, if the colon cancer is limited to the colon itself, there's no evidence of it spreading anywhere or metastatic disease, it's considered a surgical disease. So the operation there would be resection of wherever this may happen to be. So colon and rectal cancer can sound very similar, and the colon and rectum essentially make up the two components of the large intestine. So the colon is the longest, which is usually about 5 to 6 feet long for some folks, and the rectum is usually about 5 to 6 inches long. It's the very last portion before it connects to the anal canal. The real difference, aside from just anatomical location, is some of the treatment pathways. They tend to respond differently to certain either chemotherapy or radiation strategies. It also depends on where the tumor is located within its individual structure as far as the resection that would be recommended. Most adenocarcinomas, which are the most common type of colon cancer, arise from an adenomatous polyp. It depends on the characteristics of the tumor as well as the patient's overall picture. Meaning, is the cancer limited to the wall of the colon? Is there any evidence of distal metastatic disease? And is the patient physically fit for surgery, or can they tolerate a surgery? If a colon cancer is limited to the colon and the patient is physically fit for surgery, then that would be an operative candidate. So for some patients that may have advanced disease or metastatic disease, a lot of times we'll recommend adjuvant chemotherapy, meaning chemotherapy before surgery in hopes of shrinking this back down to the colon. That way we can obtain an adequate resection. As long as the tumor is contained to a specific portion of the colon and not spread anywhere, it's very much a surgical disease. For some patients, if they have no metastatic disease, no evidence of disease in their lymph nodes, surgery in itself may be considered a cure for that surgery, and they would be considered in remission immediately postoperatively, depending on the pathology results. There are multiple different ways to surgically excise a colon cancer. The first and foremost thing that a surgeon's looking at is, where is it? Typically, colon cancer resections are anatomic based, and that's because we want to make sure that we get a good harvest of lymph nodes or a good sampling of lymph nodes. We want to make sure that we have adequate blood supply to the two portions of intestine that are hooked back together. We want to make sure that we also have good margins away from this tumor, so that way we excise everything that we possibly can for these people. Depending on somebody's surgical history, they may be a very good candidate for a minimally invasive surgery, and that would be either laparoscopic or robotic colon resection. For those patients, there's typically somewhere around 4 to 5 small incisions. They come in that day, or same day of surgery. We perform that for them, and they get admitted to the hospital. Those patients can be in the hospital anywhere from a couple days up to a week after surgery. Most folks, it's towards the beginning portion of that or somewhere in the middle. If patients have a pretty complex surgical history, they've had a lot of abdominal surgeries before, or a very complex type of cancer, sometimes we recommend an open surgery for that. And that would be an incision down the middle of the belly so that we can get more adequate visualization or deal with whatever pathology that we need to. Those patients are typically in the hospital a little bit longer, usually around a week or so. For any colon surgery, there's a few goals that we really want to see people hit before they leave for the hospital, and that's really what determines where in that range of days it'll be when they finally go home. The first and foremost thing is bowel function. So everybody's bowels slow down around surgery, and that's from receiving anesthesia, that's from pain medicine, and that's from physical just manipulation of the bowels. So ideally we want to see passing gas, having bowel movements. We want to see that they're eating and drinking okay, up walking around okay, so that way they can accomplish what they need to do at home. Once we see all those things, we usually let people go home. And that kind of what leads to, or that is what leads to that larger breadth of, it may be a couple days, maybe up to 5 days, but most folks are somewhere in the middle. Once they get home, a lot of patients will have just some lifting restrictions, and that's just to try to prevent hernias formed down the road from those abdominal incisions. Aside from that, not much. It's really just getting back to your usual routine.